How do you study pharmacology? There are so many drugs you need to learn when you're studying pharmacology. Whether you're working in the ICU, you're about to start clinicals in the operating room, or you're studying for your CRNA school interviews, pharmacology is a subject that's intimidating to a lot of people and can feel really overwhelming. Anna, I know you just started shadowing in clinical and you had to take on a lot more medications that you weren't previously using in the ICU. What was that like for you?
It's a big change, switching from an ICU nursing level of understanding of pharmacology to an anesthesia student or an anesthesia resident level of knowledge that's expected for pharmacology. I have one little quick story about that. It was one of my first days shadowing in the OR, and then my preceptor holds up a syringe of lidocaine and he says, "How many milligrams is this?" He's standing about 3 feet away, and then I know vaguely that the dose that we're giving for lidocaine is 50 to 60 milligrams. I can't see how many milliliters is in the syringe, and then the expectation is to know the concentration of the lidocaine and then to be able to then extrapolate like what the dose of lidocaine that you're giving is. And I said something along the lines of, "Oh, I think it's about 50 milligrams." He's like, "There's no about anything in anesthesia. It's either this dose or it's that dose. How much lidocaine am I about to give to this patient right now?" And that was kind of a jarring, like eye-opening experience of not only do you need to know the mechanism of action of these medications, but also all the different formulations and the concentrations, and to really just know these medications inside and out. And then preparing for those clinical days, I realized that I had to prepare slightly differently. So handing it back over to you, Chrissy, do you want to introduce yourself and like talk about like why you do what you do and who we are before we get into like how to study for all of this stuff?
Yeah, for any new people here, we'll jump into the quick introductions. Like you mentioned, my name's Chrissy. I'm a certified registered nurse anesthetist. I've been practicing for 6 years. Before that, I was a cardiovascular ICU nurse. I took care of open heart patients. And together, I've partnered with Anna. Anna, I'll let you introduce yourself, but together we bring you Confident Care Academy.
And my name's Anna. I am a second-year student registered nurse anesthetist. And like Chrissy, prior to anesthesia school, I was a CVICU nurse. I also travel nursed for about 2 years throughout the COVID pandemic. We found that there is a huge gap in education for critical care nurses and for people who are starting their anesthesia school journey. And that's why we made the educational resource and the membership, Confident Care Academy membership. You guys can all check that out, where we do monthly lectures, lives. We have a bunch of resources in the membership, but then we also have the podcast where we make a bunch of free educational content. We're also on pretty much every social media platform, so follow us everywhere that you like to get content. I feel like that kind of leads into it. So Chrissy, you've been a CRNA for 5-6 years now?
Yeah, 6 years. 6 years in July.
Wow, that's incredible. So how do you recommend people approach studying for pharmacology, specifically for anesthesia?
This is, okay, I like the story that you told in the beginning, because I think this is a very common pain point when people are transitioning to the OR after working in the ICU. As ICU nurses, there have been so many guardrails put up when it comes to medication administration that it's really easy to kind of bypass some of those more basic safety steps, like knowing the concentration of a medication, how many milligrams per ml. You're not necessarily memorizing the concentration for every drug, or maybe you kind of do subconsciously because you're giving the same IV push meds over and over. But most of your medications in the ICU are typically either continuous infusions, and you know those drugs inside and out, or maybe it's like those safety injectors. Like, for example, when you give Dilaudid, it kind of comes in like that one-time dose syringe, and you're not necessarily doing the act of like pulling it up, labeling syringes, looking at the vials, and having quite as many medications to choose from, right? Like someone has prescribed you the dose, it comes up in the MAR, you scan the barcode, all of these different things are set up to kind of like dummy proof it, which is great for patient safety, but sometimes I think it makes us turn off our brains to all of the steps that we're actually executing. So when you get to the OR, the stakes are higher, all of those guardrails are off. How are you going to memorize everything you need to know about each drug? You're the one deciding whether to give it or not. You're not getting orders anymore from a doctor. It's now all on you. So the indications, the contraindications, the dose you're going to give is your choice now. And on top of that, you also have to do all these extra little steps that you didn't do as an ICU nurse. So the first tip is to learn how to study. We have an entire YouTube episode on this called Science-Based Study Tips. I believe the title is also called How to Study, and we'll pop up an image of that on the screen, and we'll link that below in the description so you can check that video out later. But one of our big takeaways from that episode was you have two main ways to study that have been proven to be successful across lots of different subject matters, as well as helpful for all types of learners. So the first way is practice tests. You're going to quiz yourself on this information. And the second one is spaced repetition learning. Anna, I know you have dived super deep into that. Do you want to describe a little bit about what spaced repetition learning really means?
Absolutely. So not to spoil that other episode, which y'all should all definitely go check out, but distributed practice and spaced repetition learning have been so key throughout the first 2 years of CRNA school. There's just way too much information to learn all at once. And I think in nursing school, often you could kind of pump and dump information, like you would cram for your cardiac exam, but then you can move on to your reproductive exam. Anesthesia training has been really modeled to continually build upon itself, because by the time that you get to clinical, you don't need to just know something about cardiac. You need to know cardiac and OB and respiratory, because you're going to be taking all of those cases every single day. So spaced repetition learning is so key. And I utilize this in a lot of different ways in anesthesia school. I utilize both practice exams, utilizing a ton of different resources. I use Apex and Prodigy and Miller anesthesia for practice questions. I use Anki for spaced repetition. I will also utilize teach back method. And this is all really, I think, this gets into so many other episodes that we've done. Y'all should definitely go check those out. But spaced repetition learning, I will say both hopefully it is incorporated in your curriculum for your program itself, and you should be incorporating spaced repetition practices into your own study techniques. So tying all of that back into the medications that we commonly give in anesthesia, how do you do spaced repetition learning for those medications? I will do flashcards every single week that go over the common medications that we give in anesthesia and the common doses, indications, contraindications, and pretty much anything hopefully that I would get quizzed on in the OR. I go over those medications. And then also this comes into play the night before you're going into clinical or going into shadowing. I'm still preclinical technically right now, but anytime that I'm going to shadow, I look at my cases the night before and I look up any medications that I'm going to give, go over all of those medications once more, in addition to the flashcards and the spaced repetition learning. And the reality is that it just takes a long time and it takes repeated exposure to learn this stuff. So to give that back over to you, Chrissy, how did you practice spaced repetition learning when you were in anesthesia school?
Similarly, I think that I was maybe a little bit taken aback by how ineffective cramming in all that pharmacology knowledge really was. There is just so much to learn. And then you're learning it at such a deeper level. You have to know so much about each drug, and you will have to talk to your preceptor about it in clinical. You will get tested on it in exams. You're going to come across it on your boards. And you need that functional knowledge in real life to make real-time decisions about your patients. So it's more than just the dose and the concentration and when to give it and not to give it. It's also protein binding, liver metabolism, kidney metabolism and clearance, like all of these different things that your patient's physiology is going to affect your decision making of how much of the drug to give, if you're going to give it, if you're not going to give it. And it's constantly a balance of pros versus cons. So how are you going to take in all of this information? Another tip that I find helpful, in addition to spacing it out and that constant review. So again, not cramming it in the night before, making sure that you're constantly going back and reviewing that over time. Over time, you can space out the intervals farther and farther, but do please keep refreshing it. That's what's going to turn it into long-term memory. But the other tip I like, in addition to that, is put it in context of a story. So when you're first learning a new drug, every single little piece of information, connect in your mind to a different part of the clinical picture. So when you're learning about the liver metabolism, a drug like Propofol, if a drug is primarily metabolized by the liver, think to yourself, how is that going to affect how I give the drug to a patient in liver failure? Come up with a clinical picture and a story for every single little piece of data you're memorizing. It's time consuming up front, but once you put it in context of a big picture, you're going to remember it long term and you're going to retrieve that information faster, because now you're just not memorizing quick little facts or bullet points. You've put together a story that's easy for your brain to cross-reference. You're forming lots of different types of neuronal pathways to access that information.
I think that's such great insight. And I also want to add that that is one of the very nursey parts of anesthesia, right? You think about the clinical picture and the experience that you have coming into your clinical day and your background, and you're using that to inform your practice, right? So the years that you have in that, which what I can speak to currently is ICU nursing. I really can't speak to being an anesthetist because I'm not there yet, but I can think about all of the patients that I've given atropine to and which patients I wouldn't give atropine to. And then I can use that as I'm learning more about atropine in anesthesia school. And then I can immediately picture the physiologic effects and then patient populations I would maybe want to avoid atropine in. And that all of those pieces just came together for me, Chrissy, as you were saying that and talking about it. It's like, oh yeah, that's very nursey to like think of a patient scenario and your interactions with that patient as you're learning more about the medication. And I think that's beautiful. I love that.
Yeah, you have that framework, you have that experience. Might as well put that together. I think a lot of times as a nurse, you kind of get the Cliff Notes versions of the story. So you'll learn like, oh, atropine doesn't work on patients after heart transplant. And then you might ask why. And somebody be like, well, they cut the vagus nerve. And you're like, okay. And that's kind of like the end of the storyline, right? When you learn it in school, you're going to take that 10 times deeper. Like, how does atropine work? Like, what does that really mean? Like, how does the parasympathetic nervous system work? You're going to take it 10 steps farther, and the whole picture is going to come together for you clearer, and it's going to help you remember other little bits of clinical pearls along the way. Our last episode that we just posted was your first induction of anesthesia, and we really drove home in that episode how important it really was to come prepared memorizing drugs. This is the number one thing that is going to make your first induction smoother, your first days in the OR smoother. If you come in with this knowledge already, people can kind of take a sigh of relief. They know that you're prepared. They know that you're a good learner. They know that you're eager. So they're going to be a lot more likely to let you do more hands-on skills and start to teach you some other things because you've already shown them that you've come as prepared as you possibly can. So we're put one of the most common induction medications into context for you now, so you guys know a little bit more of what we're talking about. So in this episode, we're going to talk about Propofol, how it works, and all the little things you need to know about it. Of course, we can't cover every single little point, or else this would be a 3-hour lecture and probably 3 different textbook chapters. We do have a lecture on Propofol in the Confident Care Academy membership as well, so make sure to go ahead and check that out. We love our in-depth lectures there, but we are going to go and dive into it today. Before we get to that, we would like to take a minute to talk about our sponsor of today's episode, Picmonic. We love Picmonic because it uses science-based learning tools to help improve recall. We already talked about practice exams and spaced repetition learning. Picmonic has that built right in. They have tens of thousands of practice questions to make sure you're studying effectively.
The adaptable format of the practice question banks combined with the Picmonic memory tools and explanation videos, they reinforce concepts from multiple angles so that you can truly gain understanding as opposed to just memorizing concepts. Picmonic serves over 1.6 million healthcare students, and it uniquely focuses not only on passing exams, but on concept retention and on clinical understanding, which is going to make you not only a successful test taker, but a stronger clinician both now and in the future.
Make sure to check out the link in the description to figure out which Picmonic program is right for you and use our code Confident Care Academy for 20% off.
So we said we would talk through Propofol, which is used constantly in anesthesia. So Chrissy, as a preceptor, someone who teaches student registered nurse anesthetists, what do you expect us to know coming into the OR? What are the categories of knowledge that you expect us to have coming in?
You guys are going to think I'm such a mean preceptor, but I really do expect you to know pretty much everything. Unfortunately, it's just our job. I have to set the bar high, and I'll be really nice about it if you don't know the answer. We're going to talk our way through it, though, and I do expect you guys to memorize it. So some things right off the top of my head that you'll need to know: the class of drug, the mechanism of action, the indications, why are you giving it, the contraindications, why would you not give it, how is it metabolized, how is it cleared, the pharmacokinetics of the drug. So you have to understand the volume of distribution, and are we going to change our dose based on total body weight or ideal body weight or lean body weight. Those are really important things to know as we care for patients with different body habituses. The onset of the medication, the peak effect of the medication, the duration of action, what are some side effects that could happen? All of those different things are stuff we're going to talk about when you hit the OR. So let's do an example of Propofol, and let's say you're getting ready to hit clinical, you're new to the operating room, You've probably learned at the nursing level that propofol puts people to sleep. You might know that it's a sedative hypnotic. You might know that it works on the GABA receptors. But we're going to take it much, much deeper when you hit your anesthesia training. So let's start chatting about it a little bit here today. So I mentioned that propofol is a sedative hypnotic, and I know a lot of you guys have used it as infusions in the ICU. In the operating room, we are giving much larger doses up front to induce general anesthesia. We can also use it as an infusion at low doses for conscious sedation, moderate sedation. Propofol works in a dose-dependent manner, so the higher it goes, the deeper the sleep. We could even run the drip super high to maintain general anesthesia. So Anna actually wrote our Propofol lecture in the Confident Care Academy membership. So I'm going to let Anna get a little bit deeper into how that really works. What's the mechanism of action of Propofol?
Propofol is a medication that I used a lot when I was an ICU nurse, and I knew that it would put people to sleep. And I knew that it had something to do with inhibiting neuron transport in the central nervous system, but I didn't truly know the mechanism of action really until I was studying for interviews for CRNA school. But kind of briefly, not to spoil the lecture in the membership too much, it is a GABA A receptor modulator, which means that it's a GABA A agonist. GABA, of course, being the primary inhibitory neurotransmitter in the central nervous system. So GABA, when it's activated, binds to the ligand site, which are these proteins that bind to GABA. It binds to the GABA A receptor, the channel is open, and that allows chloride into the cell. When chloride comes into the cell is becoming more negative, which results in hyperpolarization of the cell, which then makes it less likely to fire and then send that impulse to the next neuron, which then prevents the release of excitatory neurotransmitters. It essentially stops communication between those two different neurons. So essentially, GABA A, which is a subunit of the GABA receptor site, is turned on, it's activated. A ton of chloride comes into the cell that then makes the cell more negative, and then the cell is not going to then communicate to the next cell. So that is how these patients end up going to sleep. But there's even more. That was still kind of a surface level overview. Chrissy, do you want to add a little bit about what type of modulator propofol is and what a positive allosteric modulator means? Because there's even more here.
Yes, there's another layer to it. So yeah, it's a PAM, a positive allosteric site modulator. So because propofol is not itself directly binding the GABA A site and making this process happen, how is it affecting this channel? How is it acting on this receptor? What it's actually doing is making the GABA A receptor more responsive to your body's own natural GABA chemical. So when the receptors do bind GABA, it's going to increase the frequency of the opening of the chloride channel and really enhance that hyperpolarization, making it harder for the cell to depolarize, fire, pass on nerve impulses to the next nerve, slow down that communication and make you sleepy.
So just to circle back to that, we're saying that a positive allosteric modulator, a PAM, is working on increasing the frequency of the opening of these chloride channels, and then that's how propofol works, because that was something also that I had to read a couple times.
Yes, no, it's very confusing. So if I were to break it down like in the most simple language, and this is like why Teach Back is so good. So you have this chemical floating in your brain called GABA, right? And it hangs out in the synapses, and when it binds its receptor, the GABA receptor, it's not really uniquely named, it is going to cause the chloride channels to open. When chloride comes in, like you said, the cell gets more negative. When the cell is more negative, it's less likely to fire and send on communication throughout the nervous system. The positive allosteric modulator, the PAM, or the propofol, is going to come in, and an allosteric site is just, I guess the best way to like kind of back this up is receptors are like complex proteins, right? It's not just kind of like a door that opens and closes. That's an oversimplification. They have different subunits and multiple different binding sites. So propofol is going to bind to the GABA A receptor and allosteric site. So it's not binding to the place where GABA normally binds. It's binding to a different part of the receptor protein itself and just making the receptor more responsive to GABA. So, a lot of our drugs, when we learn about them, we're like, oh, they're agonists. They're turning it on. They're in that lock and key model. They sit in the receptor and they open the door. Or it's an antagonist. It blocks it. This is a little bit different. It's binding to a separate site on the receptor, and it's making the receptor more responsive to the natural chemical that already exists in your body.
I think that's a really good way to tie it all together, because I definitely remember learning things are either an agonist or an antagonist. I think as deep as we went was things being like partial antagonists. I didn't ever really touch on allosteric modulation until CRNA school, but I think that's a great way to say it, that it essentially causes the channel to open more frequently by binding to a separate site. That then hyperpolarizes the cell, so then the neurons don't communicate to each other. And if you like this stuff, come to anesthesia school and take pharmacology, because you'll have so much fun. So then moving on, we now know the mechanism that these cells are hyperpolarized, meaning they're very negative, and then the impulse is not transmitting from one neuron to the next. What's the physical result of that? And then what do we see as the result of that?
Loss of consciousness, right? In a dose-dependent manner, which anyone who's already a nurse knows this. If you run your propofol at a low dose, your patient's going to be awake. You crank up the dose, they're going to get sleepier and sleepier. I think it's really important to note that, and we'll get into this a little bit later too, but the longer that the propofol infusion is running, if you're giving it as an infusion, it's going to accumulate in the tissues, and you will need less of a high dose for the same effect. You can actually start to come down on your propofol infusion slowly. It's not just like an on or off switch. But when we're talking about giving a one-time dose for anesthesia, induction of general anesthesia, the higher the dose you get, the quicker the onset, you're going to put your patient to a deep enough loss of consciousness to induce general anesthesia. We're going to get into some of the more nitty gritty that I think people often mistake for being boring. But again, when you put it into the whole clinical picture, I think it becomes a lot more memorable and a lot more interesting. So let's get into some other effects of propofol besides just making you tired or putting you to sleep or causing loss of consciousness. What are some things that you've seen personally once you started shadowing in the OR? I could think of one thing that really shocked me as when I first hit the OR with propofol.
I think the dose is pretty surprising. In the ICU, we use such different dosing parameters for propofol versus for general anesthesia. So that was one of the big first surprises for me in the operating room. What would you say to that?
Oh, yeah. I mean, the dose for general anesthesia for an adult is anywhere from 1 to 2.5 milligrams per kilogram. So you're often drawing up a 20 ml syringe and giving possibly the whole thing. If they're a really young, healthy person, you might drop 2 syringes and give even more than that. And it just feels like you're giving a lot. Another really interesting thing that is like a strange effect of propofol is it burns. It burns in the veins. And because all my patients had central lines or PICC lines or midlines, I had no idea. You can kind of mitigate that by giving lidocaine beforehand. You have to make sure you actually let the lidocaine dwell in the vein, though. You can't just push the lidocaine and 5 minutes later push the propofol and hope it's going to work. That doesn't do anything. The lidocaine needs to actually act on the vein itself, but propofol burns a ton and patients will really complain about it. And it's you feel really guilty. So another thing you could do is make sure you're choosing a larger vein if you have the option. That also seems to really help decrease burning. So let's get into some side effects, besides the burning. What have you seen clinically, or what have you come across in your studies so far? Other things propofol can cause.
One of the big things that we always learn in conjunction with learning about the cardiac and respiratory system is the dose-dependent cardiac depressant effects of propofol. Some older textbooks will say to avoid propofol entirely with a very reduced ejection fraction. And I now know a little bit more that there's some clinical judgment that's involved there than just using lower doses and other medications and all of these things. But it is interesting to look at the dose-dependent cardiac depressant effects of propofol, also dose-dependent respiratory effects of propofol. Tripping on my words already, and I'm not even in the OR. Shout out to all of Chrissy's students. I'm kidding. But another big thing that we do see is also the dose-dependent vasodilation, which then, especially right after induction of general anesthesia, where you've given a large dose of propofol, to be on the lookout for that vasodilation and decrease in the SVR, and then how you're likely to see a drop in blood pressure in relation to that. But one of the biggest things, which I'll hand it back to you, Chrissy, because you do cardiac anesthesia, and I'd be interested to hear your feedback on this, but we definitely learn with very sick hearts to consider dosing separate medications for for induction for patients who have like an EF of less than like 25, something like that is what I usually see in the textbooks. What would you have to say about the dose-dependent cardiovascular depression effects of propofol?
It's interesting. If you like read about it, I think that it's very nuanced, like everything in life. But yes, you definitely see the drop in SVR. You definitely see a drop in blood pressure. And for patients who are very, very brittle with very severe heart failure, if you give a normal induction dose, you can absolutely kill them. You do not want to do that. Traditional textbook teaching will tell you to switch to etomidate. I think that just switching straight to etomidate is not always the answer, because etomidate also has a lot of really nasty side effects. It has a lot of issues of its own. I think a lot of people really take a more balanced approach where you'll mix several other types of medications for an induction of a patient with severe heart failure. So maybe we'll rely a little bit more heavily on opioids, or maybe we'll do a combined like inhaled induction of anesthesia where we're using our inhalational anesthetics through the mask in combination with some opioid like fentanyl, in combination with extremely low doses of propofol. And we'll just take our time and go slow. And we'll just like wait and watch the patient go to sleep. You might run a norepinephrine or nephrine or phenylephrine infusion with induction, depending on the patient's physiology and what else is going on. You might, again, switch to even ketamine. There's lots of different options there, but I think the key take-home point is to make sure you are reducing your dose significantly, being patient and waiting. A nice trick I like to use is to actually look at the clock when I'm inducing, and then I can kind of check myself when I'm waiting a long time, like, okay, how much time has actually passed? Sometimes it feels like you're waiting a long time and it hasn't even been 60 seconds. So it's nice to have that frame of reference by keeping your eye on. That's relatable. Yeah, it's like crazy. The time kind of like flies and goes slow.
And that's the classic experience of being, an anesthesia learner, is things go very slow and then also very fast at the same time. That's all really helpful, Chrissy. It's super interesting.
Yeah. So let's get into some more of the nitty gritty. So dosage, we already mentioned for adults was 1 to 2.5 milligrams per kilogram. For pediatrics, I think a lot of people will say something like 2.5 to 3.5 milligrams per kilogram. But again, pediatrics is a very loose term. Like that applies to like much younger children. As children get older, their physiology becomes a lot more like adults. So, I think it's safe to give people what they need. And if you need to give more, you just give more. You could always give more. You can't take it back. So I usually start out on the lower end of dosage ranges and then just give more as they need it and take my time and be patient as long as it's safe to do so.
Patience is a virtue. Patience is a virtue. Okay. More nitty gritty. What else do you have?
Let's go over, I love this one. Let's go over some contraindications. When would you not give propofol?
So in reviewing when you would not give a propofol infusion or an induction dose of propofol, my first go-to is that severe cardiovascular disease with a very significantly reduced ejection fraction. However, like you just talked about, that's not an absolute contraindication, and you can use multimodal approach. Really, in learning about propofol, there's a whole block in our board's preparation materials about the way that propofol is prepared and the egg products and allergies and all of this stuff. The TLDR of all of that, from my takeaway and understanding, is that oftentimes people can have an allergy to egg products and then still receive the version of propofol that's distributed in the United States without an issue. But if you do see that there's an allergy to propofol, you might want to investigate a little bit further. Do you have anything to add to that, Chrissy?
Yeah, so true allergies to propofol itself are quite rare, but you can technically be allergic to any drug. So if your patient has a known history of allergy or anaphylaxis to propofol, please do not give it. I think I saw a few studies that said like 1% of the population. I have a hard time even believing that. I can't tell you how many anesthetics I've done, and I think I've only met one patient ever in my career who has had a true allergy to propofol. But they did. I did see it one time. Other than, like, not in my OR. They had a previous anaphylactic reaction to it, which was kind of wild. The soy and egg thing. Propofol is made from soybean oil and egg lecithin. Did I say it right? Lecithin? Lecithin. Lecithin. No, this is my first time saying it out loud. I've written it down so many times. Okay. But the point is that, so if you have a soy allergy or egg allergy, the propofol package insert by Pfizer actually says that it is a contraindication. However, when patients have food allergies, they're allergic to the protein in the food, and the component that's going into propofol itself is just the oil. It's used to emulsify and stabilize the drug in solution. So patients are not typically allergic to the oil in these products, and multiple studies have been done. You guys, I actually thought about linking them, and there was like 1,000 out there. There's a multitude of studies that have been done that said that there is no increased risk of an allergic reaction for these patients. So most clinicians now are just going ahead and giving the propofol. If you're ever in doubt, you could always do a test dose. You just give like 1 ml, you wait. We have all of our emergency medications in the room. Of course, you want to investigate the history further, if they've ever had anesthesia before, if they've ever experienced propofol, but most clinicians would say to go ahead and give it. That does seem to be the consensus in the anesthesia community. The other thing I would consider contraindication would be a history of propofol infusion syndrome. It wouldn't necessarily be a hard stop for me for giving like a one-time dose to induce general anesthesia. I might consider avoiding it, but I wouldn't 100% rule it out. Propofol infusion syndrome happens when patients are on propofol infusions for many days, and it can be like a fatal occurrence, but it doesn't necessarily mean that it's going to happen, with a one-time injection. That being said, it would give me pause, and I would probably prefer to avoid it if I could. So what have you seen for things like, I really want to talk about like onset and distribution, because I think these are like the things that are more minutia and people want to eye roll about, but it's interesting. So what have you seen about onset in the textbooks that you're reading?
Onset, I've seen right at 30 seconds, typically, especially for these induction doses that we're using for induction of general anesthesia. Usually says 30, 45 seconds for onset of propofol from my reading. Do you teach differently?
No, I think that's 100% correct. If you're giving a traditional induction dose, right, you're giving like the full dose and the weights per kilogram for the patient. But that kind of shocked me when I hit the OR, because as an ICU nurse, you're just starting a drip and it feels like it takes forever to quote unquote set up. The reason why that happens is because of distribution. And distribution is something you'll have to learn when you study pharmacokinetics if you haven't gotten there yet. But when we give an IV medication in a big bolus, it behaves differently in the body than when you start an infusion slowly. So when we first give the medication, it's going to rapidly distribute out into the periphery. It crosses the blood-brain barrier and affects the central nervous system very quickly. And then it kind of gets like slowly redistributed to like our organs, and our fat takes it up, and our blood concentrations and the amount of free propofol available drops really fast. So after a one-time dose of propofol, it has a pretty short duration of action. It goes away in about 5 minutes. I think you can read in the textbooks like 5 to 8 minutes or something like that. And that's true clinically. That's what we see in real life all the time. Again, that was really different than when I was an ICU nurse, and my patients would be on propofol for 3 days, and then we'd turn it off and we'd wait for hours for them to wake up. So that's because it's slowly accumulating in the tissues and building up stores. And then once you turn off the drug, you're no longer infusing it into the bloodstream. You have a new concentration gradient, right? It's going to slowly leach back out of the fats and out of the muscles and out of the organ beds and go into the bloodstream and continue to have its effects until it's completely metabolized and cleared. So we started talking about duration and distribution. What about metabolism? How is propofol primarily metabolized? What organ does most of the work?
This is another thing that I really dug into in anesthesia school, and not so much as an ICU nurse. And it's been really interesting to kind of learn about how the disease processes will affect the medications that we use and the doses and all of this good stuff. But essentially, broad bird's eye overview is that propofol is largely metabolized by the liver, about 60%, and it is processed by the CYP 450 system, which if you want to know more about, definitely go check out the lecture in the membership, because we just finished the liver lectures. Of note, propofol is also about like 95 to 99%, protein bound, specifically albumin protein bound, which is going to really come into play for our patients with liver disease and liver failure, because patients not only have an increased processing time, but then they also have a decreased production of albumin. And this results in a higher unbound fraction of the drug, which is then more available for uptake. And then it sticks around in the body a lot longer, which is kind of a broad overview way to say it, that a lot of it is processed in the liver, and then liver disease affects the clearance of propofol. We can also talk a little bit about how the distribution half-life and then consequently the duration of action is prolonged for these patients. So again, if you have liver failure, you have altered liver function. You also have decreased production of these plasma proteins like albumin. You're going to then have a longer duration of action, which is going to definitely affect a lot of our patients who are often sick, right? A lot of patients have multi-system disease progression, and some have end-stage liver disease, and that's really going to affect how we choose which medications we choose for our patients. It's super interesting. Also, I'll just sprinkle in there, about 30% is metabolized by the kidney, but renal dysfunction doesn't significantly decrease the clearance of propofol. And then we also have a little bit of metabolism in the lungs. It's not a huge component for the metabolism, but some pulmonary uptake does occur, and this influences the initial availability of propofol. So overall, propofol is distributed a lot of places, but it's mostly metabolized by the liver. As far as metabolism and clearance, those are two very separate things, and I think that I used to confuse the two a lot. The metabolism of medications is like breaking down the medications, and sometimes also then binding to proteins and all that good stuff. And then clearance is how it gets out of the body, right? So clearance and metabolism are different, but about 80% of the medication is cleared by the kidneys, so 80% renal clearance, and it takes about 24 hours to get rid of most of those metabolites, which is kind of interesting as well. So also the central to peripheral distribution of the medication, which is then like how we see the patient go to sleep so quickly, that's the main reason we see such a fast recovery of the effects as well. Propofol is pretty fast on, fast off, and also it's cleared from the body pretty quickly unless you have advanced liver and kidney disease.
I'd like to kind of connect that back with contraindications, right? Does that mean that if your patient has liver failure, you can't give propofol? Absolutely not. We give propofol to these patients all the time. But it does mean you're going to significantly decrease the dose, and you're going to anticipate a slower wake up potentially. It might hang around for a little bit longer. It might take these patients a longer time to metabolize and break it down. Of note, when we talk about how not all of the metabolites are cleared until about 24 hours later, it doesn't mean that you have active propofol that is pharmacologically active floating around in your system. The metabolites are like the breakdowns or the byproducts, and drugs often have metabolites that are inactive, meaning they don't have any systemic effects, or they don't have that primary action. And some drugs do have metabolites that are active, but propofol's metabolites are not active, so they're not causing additional sedation for the most part, at least the majority of the metabolites. So even though these patients do have some of those floating around for the whole next day, it doesn't mean that they're going to be unconscious any longer. But definitely decrease your dose for these patients, and definitely expect a longer wait time for wake up. Similarly, if your patient has renal failure, it's still okay to go ahead and give it. There's multiple studies that have shown that even in patients with renal failure, they still do clear the propofol, which is good news for us because it's one of our favorite drugs in anesthesia.
So if you were to ask somebody who is interviewing for CRNA school to describe propofol, what would you expect for them to say? Like, what level of knowledge would you expect from?
So if you're currently an ICU nurse and you're applying to CRNA school, I would expect you to have more than a nursing school level of knowledge, but I wouldn't quite expect you to know as much in depth as what you would need to for, in the operating room. I would expect you to know that it's a sedative hypnotic. It works on the GABA receptors. I would expect you to know what GABA does. I would like to hear you articulate that it opens up the chloride channels and it hyperpolarizes the membrane so that the neurons don't fire. I think that would be like an appropriate level to kind of end that conversation at. I don't know if you necessarily need to quote back to me about positive allosteric modulators. I think that's a little bit of a layer deeper. In fact, a lot of the textbooks don't even talk about that. That's something that I've come across in like really digging into like pharmacology articles and like original research when they were like doing drug investigations. So that's not something that is commonly talked about. I would expect you to articulate to me how you dose it in the ICU, any contraindications, so patients that you might be wary of giving it for. I would expect you to understand the concept of a context-sensitive half-life, meaning the longer the infusion is going, the fact that it does build up in the tissues and that you're going to eventually decrease the dose over time and turn it off. We didn't get into detail on propofol infusion syndrome here today. I think that could be like its whole own episode, honestly, but I would like you to articulate that is like a possible issue of propofol. There is a risk for that happening. I don't know. What else do you think, Anna? Anything else that you came across in your interviews, or anything you would add or take away from that?
Yeah, I think that's great, Chrissy. I would just add, for people who are in the preparation for anesthesia school process, to just practice out loud over and over again, talking through not only your emotional intelligence questions, but also your answers to your pharm and your pathophysiology questions. So you can be in the car driving to your job and then talking out loud to yourself about, I think the way that I articulated it when I was interviewing for anesthesia schools was that propofol was a GABA agonist, and then it would open up the chloride channels and hyperpolarize the cell to stop communication between neurons, which then causes sedation and hypnosis. And then I would talk about the dose, So you want to be able to just kind of articulate in 1 or 2 sentences and then kind of tie it up in a nice little bow. I don't think that you need to know every single thing that we talked about in this episode or in the lecture and the membership in your little 2 to 3 sentence overview. But I do think it's really helpful to practice articulating that. And then also, of course, from the articulation, you need to understand it at the level before that. And then I think also, Chrissy, one last question. So as a student in the OR, would you want me to do a whole blurb from beginning to end, everything from the class to the contraindications as I'm drawing up medications with you? Or is it more of a, you're asking questions as we're dialoguing throughout the case? How do you usually approach that with your students?
Every preceptor is different. There are absolutely people who will go ahead and drill you on every single little thing. I had a preceptor who made me go through every detail of every drug before we induced anesthesia, and I had to say every little thing about every single drug before I was allowed to do anything for the day. I don't think most people do that. I know other people will do the drug drawer thing. They'll go to the Pyxis or Omnicell and they'll open it up. That's something that kind of shocked me too, right? As an ICU nurse, every time that you pick a drug on the medication dispensing unit, one drawer pops up with your vial. In anesthesia, you just open the drawer and they're all there, and it's make sure you don't mix them up. You got to really look at your vials, guys. There's no more barcode scanners. Pay attention to your 5 rank. But also, people will literally open up the drug and they'll just point to drugs in the cart and make you rattle off the facts about them. I don't do that typically. I like to have clinical conversations about what's happening in real time, so that we're always putting it together in context of safety for the patient and situational awareness. So this is this patient's past medical history. Okay, so would you still give this medication, or how are we going to change the dose? Okay, why would you do that? Okay, well, what if the patient had this disease instead? Would you change your plan? What if this emergency happens? What are you going to do next? What is a way that we can mitigate this side effect? There's so many more things about propofol we could have talked about. Another really great use for it is it has really awesome antiemetic properties. It can help prevent nausea. So I love to use a PRN infusion during general anesthesia for anyone prone to nausea. So that's something I might want to talk about. And then go off onto a side tangent about what are other ways we can prevent nausea. So constantly taking these obscure facts about clearance and metabolism and onset and duration and all of these different things, and always putting it together with a story so that you're always thinking about the patient and pulling that information together. So that's how I encourage you guys to learn about the drugs. For every single little fact, connect it to a clinical pearl, a patient that you're picturing. And then again, when you're going back to study it, flashcards with all the bullet points, and just use that spaced repetition learning and practice testing so that you can really nail that down.
And have patience with yourself, because you can't learn 5 years worth of clinical practice knowledge in 2 months. So be thorough, and then also trust the process. I can find there's a lot of frustration sometimes of going from feeling competent and good at your job as an ICU nurse to being a learner again when you're in anesthesia school. So just do the work, put in the time, and trust the process. And then know that, me as a second year SRNA, I'm not going to know everything that Chrissy knows as somebody who's been a CRNA for 5 years. I just you can't, until they invent a brain transplant, you have to just acquire that knowledge through spaced repetition and through being in clinical practice every single day. So do the work, trust the process, be nice to yourself. And then also, I like how you keep tying it back, Chrissy, to the clinical picture and the patient scenario. And I think that's a really good way to kind of picture each patient interaction and how to tie that to your learning. I really like that.
Oh yeah, absolutely. That's the only way I got through CRNA school. Guys, if you like this episode, please make sure to subscribe. Our next video is going to be on how to prepare for your CRNA school interview. I know that's why a lot of you guys are here. So we're going to get even deeper into that. We have everything linked down below in the description, our how to get better grades video and your induction of anesthesia video. So make sure you check those out. If you're looking for more in-depth pharmacology review, definitely check out the Confident Care Academy membership, and we'll see you next time. Thanks.
Bye.